Hi, my name is Mike Ajuria. I'm one of the chief residents here at Highland, and I'm here today to tell you about hyperkalemia. This is something that you will see very often as an intern, and you need to know how to manage it. So our objectives, I want you to be able to appreciate the dangers of hyperkalemia. You will describe the pathophysiology of why it happens. I want you to be able to understand the mechanism of action of some of the treatments that we use, and then we will implement treatment plans using some cases. So why should you be listening? As an intern, why is this important to you? So on wards, you check a patient's potassium and it's 6.5. If you leave it alone, don't do anything about it, this can lead to EKG changes, which can lead to a code blue being called and 20 doctors running and screaming. And this can lead to death. So it's important to be able to understand what to do in the circumstance. The most dangerous sign, so you want to look at the EKG changes. This is a sign of impending doom. So with mild hyperkalemia, so a potassium of 5.5 to 6.5, the most common EKG changes are peak T waves, seen here. You can also see a prolonged PR segment. When the hyperkalemia becomes more severe, so moderate is defined as 6.5 to 8, you can see a widened QRS, the P wave goes away, and you can see some ST changes. With very severe hyperkalemia of greater than 8, you can see sine waves and then fatal arrhythmias such as VFib and asystole. It's important to notice that any level of hyperkalemia here can cause EKG changes, and they may not be specific to a level of these hyperkalemia, a level of this potassium. So there are three main causes of hyperkalemia. So the first cause is just too much potassium in the body, total body hyperkalemia. Another cause is due to intracellular shifts. So there's too much potassium in the blood compared to the intracellular space. And finally, there's too much potassium in the lab sample compared to the blood. So this is called PseudoHyperkalemia. So we'll go through a patient's BMP. So you get this lab back. You see the patient's potassium is 6.3, and it is high. So go ahead and click on that sample, and you get this reading back. And it says that there's no visible hemolysis. So in some samples, they will note that there's moderate hemolysis or severe hemolysis, and that is telling you that the potassium in the sample is an overestimation of the patient's potassium. So this is pseudohyperkalemia. And what this is due to, so if the red blood cells in the sample are lysed, there is a release of a bunch of potassium into the sample, so it elevates the potassium. The second cause of hyperkalemia is due to intracellular shifts. So in this patient sample, the glucose is 591, the CO2 is less than 8, and the potassium, you'll notice, is 5.2, so mildly elevated. So does this patient have hyperkalemia? Well, yes, but the patient does not have a total body hyperkalemia. So what this is due to, the patient has a lack of insulin. So what insulin does normally, it stimulates this sodium-potassium ATPase pump, and in return, the sodium-potassium ATPase pump pumps out sodium and pumps in potassium. So normally, your potassium is mostly intracellularly, and not much is extracellular. So when you have a deficiency in insulin, this pump does not work, and more potassium than normal is outside of your cell. So you have hyperkalemia in your blood sample. Some other things that activate this pump are epinephrine, and something that will deactivate this pump is when you have acidosis. So The final cause is just too much potassium in your body, so total body hyperkalemia. This is usually due to one of a few things. So you can have end-stage renal disease, CKD, or AKI. So your kidneys just can't pee out the potassium. Another cause is just too much potassium in your diet. So there are some foods high in potassium. Usually this is in conjunction with having something like an acute kidney injury or CKD or end-stage renal disease. And there are also causes of cell breakdown, such as rhabdomyolysis and tumor lysis syndrome. So the cells are releasing potassium into the blood. And then medications. This you will see very commonly ACE inhibitors and angiotensin receptor blockers and spironolactone. And these just aren't letting the kidneys work to pee out the potassium. And then beta blockers, if you'll remember, they will deactivate that sodium-potassium pump, so it won't let it pump out potassium. Pump in potassium. So what do you do about it? The most important thing is if the potassium is severe and life-threatening to prevent a code, you need to give calcium. So what calcium does is it stabilizes the cardiac membrane. So what you can do is give calcium gluconate or calcium chloride. What we have in our crash carts is calcium chloride, and this stabilizes the cardiac membrane. This takes about 10 to 15 minutes to work, and it lasts about 30 to 60 minutes. So remember, this is temporary, but it does give you time to protect the cardiac membrane and prevent a code blue from happening. And repeat this until the EKG improves. So you may need to give 2 or 3 doses for the EKG to get better. The second thing you want to do for severe and life-threatening hyperkalemia, you want to drive extracellular potassium into the cells. And remember, this is also temporary. So remember this diagram. So we want to be able to activate this sodium-potassium pump and drive extracellular potassium into the cells. So the way to do this is activating the epinephrine pathway, the insulin pathway, and also the hydrogen pathway. So one way to do this is to give albuterol. So this is a much higher dose than your COPD patient, but 10 to 20 milligrams nebulized albuterol activates this epinephrine pathway to drive potassium into the cells. You can also give D50 and insulin. So this activates this insulin pathway, activating the sodium-potassium pump and driving potassium into the cells. Something that you want to be careful with is patients with end-stage renal disease can become very hypoglycemic with this. So you may want to give either more D50 or less insulin. And then finally, if your patient is acidotic, sodium bicarb can help. You want to give this in conjunction with other things, such as albuterol and insulin. And then you want to get rid of the potassium, so eliminate the potassium from the body. So the first things that we were doing were temporary measures, but eliminating potassium from the body will solve your problem. So if the patient is still peeing and is fluid overloaded, Lasix works really well to pee out potassium. Remember that the worse the kidney function is, the higher dose you will need to give, and it has a fairly quick onset in about 30 minutes. If you have time, so if the patient's potassium is not so high, then you can give K-exolate. So 15 or 30 grams of K-exolate PO, and the patient will poop out the potassium. Remember, this takes some hours to work, so you don't want to give it if the hyperkalemia is severe. And if these don't work, or if the patient has end-stage renal disease already on dialysis, call renal and they will be able to dialyze the patient, and the potassium will be removed from the blood that way. So just going through these again, the first step the most important step is to protect the cardiac membrane. So this is only for severe life-threatening hyperkalemia, and you want to give calcium, so calcium chloride or calcium gluconate. You can drive extracellular potassium into the cells. This is also temporary and for severe life-threatening hyperkalemia. So remember albuterol, insulin, and sodium bicarb. And then if the patient is, if this does not work for the patient, or if the patient is end-stage renal disease, you can do dialysis. And repeat these until the EKG normalizes and the potassium is fixed. So we have a case here. So go ahead and pause this video, and when you're done, we will go over the answer. So the question, in addition to IV calcium gluconate, which of the following is the most appropriate next step in treatment? So notice that this patient has severe hyperkalemia with EKG changes. So they already are telling you that they are giving calcium gluconate, which will stabilize the cardiac membrane. What we want to do next is give glucose and insulin. So this will cause intracellular movement of potassium, and this is a temporizing measure until you can dialyze the patient. Here's our next case, so go ahead and pause, and we will go to the answer when you're done. Okay, so which of the following is the most appropriate management of this patient's hyperkalemia? So if you notice, she has a reason to have hyperkalemia. She's not drinking or eating. She's also on an ACE inhibitor. The potassium is relatively mild at 5.5. and there are no EKG changes. So in this case, we want to give IV fluids to fix the problem. The main problem is that she's dehydrated. We want to hold the ACE inhibitor, and if these don't work, we can give K-exolate since the hyperkalemia is relatively mild. And that's it. Thank you for listening.